We'll now have a tea break, but before that, we'll assemble in the reception hall, ground floor, for a group photograph. So I request everyone to be there, and after that, we'll have a quick tea break in the cafeteria, just adjacent to the reception hall.
Okay, so quick tea break, so we'll be back after 20 minutes.
Of a digital health strategy, a global digital health strategy. This was requested by members in 2018 and will be presented to the World Health Assembly in 2020, or next May. This has had a lot of input and discussion globally at our regional committees and by experts who've had a look at it. And the aim is to catalyze the development of digital health tools, national e-health strategies and plans, and to use innovations that are happening in this space to advance healthcare, particularly focusing on low income and low middle income. Because the situation today is that many countries are getting really advanced in using these technologies. And I think the whole day today, you're hearing about the amazing things that can be done with artificial intelligence. But technology is outpacing the development of policy. And it would be really helpful for this group to think about what policies, what frameworks, governance frameworks would be needed in order to ensure that artificial intelligence can be used safely, ethically, responsibly, and yet allow for innovation so that we can advance in the way in which we practice medicine today. There's no doubt that there's amazing potential to use AI for diagnosis, for management, for smoothening the workflow in healthcare systems, for prediction of events, as well as personalized prediction. So almost every aspect today of not just health, but all disciplines are being affected by AI. But we also know that AI can only work if it has access to large amounts of data. And this is where the need for both governance at the national level and the global level comes. And I think this is one area, perhaps it's similar to particle physics, where you have the large collaboration at CERN, where scientists from all over the world come together to answer some fundamental questions. AI, I believe, is another area which needs global collaboration, access to large data sets, basic principles of data sharing, and establishing guiding principles for the testing and development of. And I think this is possible. Many countries are trying to do it at the national level. We would like, WHO would like to start this discussion also at the global level as to how countries could collaborate with each other in order for data sets to be even more varied, and therefore the results to be perhaps more robust. So we have set up a group to look at the ethics of artificial intelligence. And this group has met once. In fact, the co-chair of the group is Dr. Mazumdar from Calcutta. And the group will deliberate on the ethics and governance frameworks of AI. At the same time, we also have the digital health strategy that's under development and a technical advisory group that's advising WHO on the work streams that need to be pursued. And one of the important ones that came out of the first meeting is interoperability. Even in advanced countries and high-income countries, and I think, Thomas, you know about Germany, interoperability is missing. Hospitals cannot share data with each other. The privacy and data confidentiality rules are so strict that they do not allow the sharing of data. We therefore have an opportunity to build systems, particularly in the lower and middle income countries, to develop rules and regulations which enable this to happen at the same time protecting patient confidentiality and any harm coming to patients because of the sharing of data. And I think it's possible to have a framework in place. And I hope that in future that we need to focus on this. And finally, I just want to say, I just want to reiterate the importance of having a national strategy or a digital health strategy, as well as a strategy and rules data. Federated data sharing is a possibility which allows the use of large data, while at the same time does not require that everything be pooled in one place and be transferred somewhere. So I hope that this workshop that's being hosted by ICMR, WHO, and you will discuss and debate some of these issues, in addition to hearing about all the amazing advances that are happening in this field, and come up with very concrete suggestions on the way forward. As you already know, the focus group on artificial intelligence for health, which WHO and the ITU together are looking at some of these issues, particularly in certain clinical conditions where AI has advanced very rapidly. But I think that the field of AI is much beyond just clinical diagnosis and can really allow us to operate in a very different environment and have much more impact on people. So again, keeping at the back of our mind, how do we improve health and healthcare? As you know, universal health covers 3 elements: financial protection, access to quality health services, and access to quality healthcare products. And AI can possibly help in all of these aspects of UHC. So thank you very much, and I look forward to the feedback from this meeting. Thanks for giving me this opportunity to join.
Thank you, ma'am. It's always a pleasure to hear you and have your vision. Thank you, ma'am. Thank you so much.
And since you've been the DG of the ICMR in the past, we really enjoy the hospitality of your former organization. And thank you very much for your support.
Should we do selfie station?
Thanks, Dr. Soumya. So let's get into the session now. We'll move into the session that we have. Looking forward. So I think it's been a very rich morning. Good morning, everyone. I'm Samir Pujari again. Thomas has introduced me. I'm with the Digital Health and Innovations team at WHO under Dr. Soumya, and I'm also one of the vice chairs of the focus group. And our task with my very competent Dr. Vishnu Rao, who is my co-chair of this session, I think we'll try and bring the speakers, and the speakers will do the talking, and we have got a very elaborate panel. But I would like to challenge the speakers while you're presenting to look at the points, very often points that were mentioned this morning. First point was about leaving no one behind. It's about getting the individuals, the AI opportunity, to make sure that how can your solutions or the fundamentals of AI be used to apply to every single individual as well as the population group, and how do you reflect that in your discussion? The second very important point that was brought out was about scale. I think we are not doing ourselves a justice if we're sitting in this meeting and not talking about scale, because if AI is not about scale, then what else is available? And I think the third point that I want to speak here, which has been very aptly shown, is the collaboration. Getting together the ministries of health, the research councils, the Ministry of Telecommunications to host and do things together, I think is a very, very crucial angle of working together in this space of things. So I would challenge the speakers to please come in. Before I call the speakers, I'll hand over to my co-chair, Dr. Rao, to say a few words.
Good afternoon. I'm really tempted to speak 1 or 2 minutes because I am also a data scientist. So now the AI, artificial intelligence, machine learning, deep learning are the buzzwords. Every researcher, everyone uses it, and at the end of the day study, they say that appropriate AI methods will be applied. We don't know what they are. So going back to 1956 to now, I will put forward, I'll classify them into 3 categories, how the evaluation has taken place. The first one being, we started with the human-only intervention, like we write the programs, run the programs, create the output, followed by the middle one with hybrid computers and hybrid missions, and now with machine learning and artificial intelligence. So as you all know, morning has been told, data is an oil now. Oil revolution is over now. Data is oil. So machine learning is a data-hungry concept. It needs millions and millions of records to get the actual output or accurate output. And you all know that there is 5 zettabytes of data right now available. That means that 21 zeros after 1 is very difficult to count, and that is also equivalent to a billion computers, and now it will be 15 zettabytes by 2025. So therefore the data is heaping up and going up, and the success of the AI depends on the predictive, how best your predictive model is. Everyone does the predictive model, but how accurate or predictive precision, and they want to hunt their desired animal, and they found that the physicist counted the velocity and distance and fired it is 5 feet away from the animal. And again, this engineer got angry. He did not count for the air wind's direction, and again he snatched the rifle and again fired it, and it is 5 feet right of the animal. Then without firing any shot, the statistician cheered and said, "I got it," where the average is center. So therefore the prediction is done. So it is not like that prediction should be accurate whenever you're using for the applications as such. Morning, Dr. Thomas was mentioning about AI for good. I give a great example of Indian scenario where Akshay Patra is the NGO where their aim is that no single individual, no single child shall be deprived of education because of the hunger. So they just celebrated 2016 2 billionth feeding, and they are using AI for their what you call blockchain. That means the digital decentralized ledgers. They are using AI very effectively and getting the millions of meals in a right prospective manner as a quality as well as and the quantity also. And also I can put you 3 main applications of health. One is machine learning will dramatically improve the prognosis. I am just stressing upon prognosis, like acute physiology, chronic health, evolution score, or sequential organic failure assessment. And also machine learning will display much of the work of radiologists, and machine learning will improve diagnostic accuracy with, there is a lot of discussion on that. AI system smarter than the human practitioners. It is a debatable issue. Personally, I feel it is not. Therefore, we require both the human resource, means doctors, as well as the AI in place, and they should combine their intelligence both. Then only the things will be improved and AI can be successful and AI can be utilized. Thank you very much for giving this opportunity. And we have very eminent speakers. I don't want to stand between them and you. And
so I can, yes, thank you so for those very insightful words on bringing the highlight of data. So let me first call on Dr. Professor Anurag Agrawal, who does not need any introduction. I mean, I've just met him for the first time today, but I've read so much about him that I thought I knew him from a long time ago. He's the co-chair of the dataset Financial Times Commission on AI and digital work as well as a member of the WHO Digital Health Technical Advisory Group, in addition to many of his other things. But I'll hand over to him to give us some words of advice.
Thank you very much. And I hope that while I know we are short of time, only 2 minutes left does not apply right now. All right. So it's a pleasure to be here. And I think the very first slide I would want to show in the idea of fundamentals of AI for health is this. The Gartner Incorporated came out with a 5-step hype cycle. And one of the most important things when you talk about AI applications for health is to remember that every technology trigger has a peak of inflated expectations afterwards. When they're not met, you get a decline. At that point, everybody is saying it's not going to work. And then you get into what's called the slope of enlightenment and the plateau of productivity. Now, AI is pretty old. If you talk about AI in medicine, you'll find articles in 1950s talking about how computers will replace medicine. You'll find more such articles in 1980s. You look at Jan LeCun's fundamental work in deep learning, it's basically 1980s. And we have been through one hype and burst cycle before in the 1990s. So one would hope that we've already crossed the peak of inflated expectations, and now we are in the plateau of productivity. Unfortunately, in nature, sometimes things have two humps, not just one hump. So I'll talk to you about in the fundamentals is what are the key considerations we must take today. I think we are technologically capable. How do we take these fundamentals together so we don't face that double humped camel? The first and most important thing already articulated by the co-chairs, AI for good, is health is the better half of AI health. And to do that, we must remember that the purpose is not technology by itself, it's only an enabler. The purpose is to improve access, quality, affordability, equity, and justice across the world. If we keep that in our mind as the first fundamental, things will go fine. The second thing which I must say I learned partly while going with Naomi and others in Germany was that the developing world is not only the one in sore need of AI to improve healthcare. We always talk about lack of doctors. Anjali talked about that, the paucity, the demand-supply gaps. But we are used to a certain level of healthcare. It can only go uphill from there. In the West, when people are already used to high levels of healthcare, they're used to plenty of healthcare providers being in the system, and they have an aging population with people living ever longer, fewer replacements coming, and a population accustomed to high quality healthcare. The challenge is everywhere. The challenge may be of different types, but nobody in this world today is immune from the problems of healthcare. The other important fundamental I'd like to speak on is AI is the end of a process. Before AI come II, intelligent infrastructure, and non-machine learned medical systems, which could be called intelligence augmentation, IA. It takes a huge amount of data to take this forward. To start imagining AI solutions to any country's problems without investing in intelligent infrastructure, a web of physical entities that allows you to transfer data, collect data, move data around, would be foolish. At the same time, not everything requires a machine to learn everything to be done from point one again. There are important things like medical guidelines, context-specific things, medical reasonings. You don't have to reinvent the wheel for every single thing. And I would actually say that II and IA can handle about 80% of primary healthcare needs. Now we come to the third fundamental, and this will be in two parts. I'll come to the second part later. Basically, when we speak of AI, we're all speaking of machine learning. This particular ice cream comes in about 4 different flavors. One is supervised learning. You must provide labels to the data to machine to learn. Unsupervised learning, you provide the data, the machine might provide you labels that you never thought about. Semi-supervised learning, part of your data is labeled, part of it is not. And the last one, reinforcement learnings, you have to take an action. There is a continuous outcome of the action over a time series of data. The machine would learn how to make better actions. These four things describe a lot of what happens in healthcare. I'll give you specific examples. We all have heard about the Google diabetic retinopathy tool. It was absolutely fantastic at classifying retinopathy from snapshots of the retina. We all know that diabetes is one of the leading causes of blindness across the world. We all know that normal doctors, in fact, I will say I am part of them. If you ask me today to look into somebody's eyes and get a retina thing and try to diagnose, I could not do it. I would be lucky if I could just see the retina. That's really how tough it is. Using a two-step combination of technology, one creating tools that allow you to get better snapshots of the retina, that's got almost nothing to do with AI, and a second set of tools analyzing those snapshots for diabetic retinopathy, they were able to build an engine that was able to classify DR and other types of retinopathy as good, if not better, than trained ophthalmologists. If you look at the ROC curves, except for one ophthalmologist, it exceeds all of them. And you would imagine this should be easy to transplant, but they had to provide 40,000 labeled images and create those data sets to do it. And what's truly amazing to me was not this, but the fact they could tell the gender of the person from those photographs. They could tell the age, they could tell the blood pressure, they could tell the CV risk. Looking at labels that were not the primary intent of what we fed into the machine learning system, the machine learning system was able to come up with types of things that are very, very interesting. Now, clearly, I don't think we need the machine learning system to tell us the gender, although it's quite interesting, but CV risk? Being able to tell the CV risk of a person from a snapshot of the retina sounds fantastic. Of course, we would have to test this further. There are levels of medical evidence you need to meet. But I thought this was quite interesting, particularly from this angle. It's not always the label that you were interested in. It's the other labels and the inferences the ML system in supervised learning can do. And we must try to provide as many good labels as we can so we can get the maximum out of these systems. The second example comes from a semi-supervised system where you may not have enough label data. You may first want to simply throw in a lot of echocardiograms or of hypertrophic cardiomyopathy, for example, which is what you might want to detect on an automatic system. But simply from what's called generative adversarial networks, one AI creates synthetic echocardiograms. Other AI, given a lot of echocardiograms, distinguishes them from noise and tries to tell the truth. Is this a fake MRI? Is this a fake echocardiogram? Is this a real one? At some point, as the two AIs battle it out, there is some degree of understanding of what an echocardiogram is. Without any labels, you can create it. And in this particular paper, using a data set of only 1,000 labeled echocardiograms, they're able to achieve a high level of performance. And there are many other examples of semi-supervised, but this is a good one. A third one, this is from my own lab. If you wanted to know, are there types of asthma that look like each other clinically, but respond differently to treatment? How could you do it? We basically took NMR spectra from people whose breath we had taken. And from that, we were able to infer 3 completely different types of clusters in terms of clinical outcomes. And that would be an example of unsupervised learning. And the last is reinforcement learning. Given fluid and dopamine requirements in ICU, an AI clinician did a better job than human clinicians of giving fluids and dopamine. Again, very interesting. Basically, it reacted earlier, reacted smaller. Humans reacted later, reacted too much. And this is a medical reasoning system, a Berlin-based company called EDA. And people are finding this is a very useful input to them. You have symptoms, it will tell you what your likely diagnoses are. So what can AI ML IA do? It can work tirelessly, be available instantly. It can update itself, duplicate itself, lots of regulatory problems. And the last, very simple one. If you're an ICU with 20 different signals being fed into you, you really can't handle it. If I was to ask anybody in this room, just remember a phone number, anything more than 7 digits would give you trouble. How will the human brain handle 20? And that's the point of a recent article in the New England Journal, Lost in Thought, the limits of human mind and the future of medicine. If the problem is complexity, the answer is likely to be simple. Last, and ending my talk as I'm getting the looks, in God we trust, all others must bring data. When it comes to AI, the answer is maybe. The data itself could be biased. Unbiased collection of biased data does not remove the bias. And activation maps, like we were shown in radiology, tell you where the AI is looking. It does not tell you what it is seeing. So be very careful about black box systems. So are we past the hype? Yes, in some level, we are exceeding or reaching human capacity. No, healthcare is greater than the sum of specific tasks. Digital transformation in non-health industries is evident, finance and so on, but clear example of medical outcomes improvements are still relatively lacking, and that's what our commission will look forward to looking at. Complex health data handling capacity is beyond human limits, but only humans today have generalizable understanding that you can take it to other systems. And with that, I can say AI works, but not trustably in all systems. We need to be careful about that. And our commission will look into many of these questions. Any questions about it, we'll direct to Naomi. Thank you.
Hi, Dr. Anurag.
Any one question from the audience, please?
Hi, my name is Dushyant, and thank you for wonderful presentation. I like how you summarize in the end, like, have we there or not. So I just want to, get your perspective on the last state. Like, most of the time when you look at research, AI research in healthcare is fantastic. But how do you translate and make them trustworthy? Do you have any early thoughts around it? Would be happy to hear.
It's a kind of a long question to answer, but the most important thing is transparency in the process. If you have a completely transparent system of how the data was collected, what type of algorithms were used, where the validations were done, and you're able to do almost like a phase 4 clinical trial, post-marketing, you're continuously having a surveillance. And importantly, if you keep in mind, what was the real intent and what is the outcome? So if you wanted to make diabetic retinopathy detectable by the Google tool to reduce diabetic blindness in the community, the long-term answer is only one. Is diabetic blindness going down? There is no shortcut to that. There are multiple surrogate measures, but in the end, you must ask the hard question.
Thank you.
Thank you. For positive of that time, we will. Thank you so much. So our next speaker, as I mentioned, collaboration is important in this whole space of AI for health. And there's a very insightful talk from Noel. Next speaker is Shazan Parvez. I don't know if you're a doctor or not yet. But
No.
No, coming at WHO, I'm always called a doctor and engineer by background as well. But so Mr. Parvez is the head of AI and HP, and I would love to hear from you also. I mean, of course, what he's doing. But how do you see it? Dr. I just mentioned that it has to be very open and transparent,
Right.
very real. But then when you talk to the industry, they say, then where is the business for that? So what is the fine line you're going to draw between that? And
No, it's actually a pretty good point. In fact, this is the basis of my presentation today, because we've been working with multiple organizations, research organizations and industries to perfect the AI journey and implementation of their solutions. But when it comes to healthcare and medical research, we found there's a lot of data lacking to make accurate predictions for AI to work. So basically, I'm coming back to the fundamental of AI. What we see now is what we are working with different organizations, and I will take one of the case studies we did with one of the German institute for neurogenetic disease. The data is very critical for AI to function. And as you said in one of your discussions, that we have to scale the AI part of it. Now, to scale the AI part of it, we coming back to the very basic diagram which everybody is aware of in the AI world. But if you look at how deep learning works, is that you need to feed it a lot of data to build the smart algorithms, and then machine learning to make an inference out of it, and then AI to come to life. So without the data, there is no deep learning, and without deep learning, there is no machine learning, and without machine learning, there is no AI to work on. So AI has been coined in 1956, as Dr. Agarwal said sometime back earlier that in 1956 we already coined the word AI, and Japanese researchers have been already writing codes on AI. However, there was not enough data to make the accurate predictions for AI to evolve. And this boom has happened after 2010, where I think one of the chairpersons already mentioned that today we have 4 4 zettabyte of storage data available to work on the AI. And the prediction is, by the industry prediction is, by 2050, we should have 44 zettabytes or maybe crossing 80 zettabytes of data to work for the AI to evolve. However, there is still a concern when it comes to medical research and healthcare. The data is not very transparent. The data cannot be shared very in a very open way, and a lot of patients do not like their data to be shared across with other platforms. Of course, there is insurance involved and things like that, which makes more and more things more complicated. However, the boom of, so a lot of organizations we go back to, and they always start with saying that, where do we start the journey for AI? HP is one of the organizations who provide the solutions around AI, and we always encourage the research institutes to be a part of Hewlett-Packard Enterprise Labs, which actually helps organizations with their AI journeys. So the starting points could be anywhere from, because the ecosystem is evolving, there are a lot of platforms that are already in place, there are a lot of technology vendors already in place. We're already talking to over 1,000 apps which are working in healthcare and life science industry. Our own we are very rudimentary of like the Fitbits we wear or Apple Watch we wear, a lot of sensor data which is moving from the patients to the institutes, but the ecosystem is evolving faster and faster. But there's a lot of hype in this industry also at the same point, because not of all the data is making a relevant decision for us to do it. And I will come to that point later on, is having all the data possible is actually relevant to the research of AI. So at a very rudimentary level, AI is helping patients, both doctors and patients together to making this ecosystem much better. Of course, doctors get relief because now patients can reach out to chatbots. You can use NLP's transformation. A lot of apps are there for customers to talk to, for the patients to talk to the customers. In our perspective, and because we represent the industry, we're already seeing this industry is evolving, and we're already seeing in North America, this is going to touch around $3 billion. Worldwide, it's over $10 trillion, almost $10 trillion. And we don't have right data for India, but I'm assuming this data could be much higher for India, because there are a lot of people here and there are a lot of work happening on the AI. From the industry point of view, this is the good news for us, because we are helping organizations to scale the solutions faster. When we say scale, it is important that you understand that when you develop an algorithm, somebody has to take it to the market, somebody has to perfect it, and the acceptance rate for healthcare industry is over 80%. Unlike any other industry where you can take an AI solution which has an acceptance rate around 75%. But for healthcare, recently we also came to know that FDA has approved 3 organizations who've been working in the area of AI, which AI is developing drugs now for the organizations. They're already drug with, like Pfizer's are collaborating with a lot of AI companies who are actually helping them to build the drugs around using AI is developing those drugs for them. This has never happened before, and it's a very difficult task. But this is taking leap and bounds. So from the HP point of view, we are working with a lot of organizations, and this is including the biggest of the names like Mercedes and Seagate and so forth. One important point I want to bring now to the case study which we've been doing around medical research. We call it BZNE. I could never pronounce the organization name, so I keep it short at BZNE. So basically, they are the German Institute for Neurogenetic Disease. The focus here is they have. So let's say let me rephrase this. So today there is a problem. There are around 30 million people worldwide suffering from Alzheimer's, and every 20 years this disease double itself. By 2050, it is predicted if the entire GDP of US will be required to take care of these patients if Alzheimer's is not treated in time. Another disease along with Alzheimer's is autism, which is also taking its own shape and increasing multifolds year by year. This new science is now, we went to the very fundamental of AI where we talk about chatbots, NLPs, and things like that. But things have moved forward, much more faster, making much more sense for medical research. So here the goal was to put together a library of genomic research so that when the patient comes, we can reference his data with the old data and understand what level of, what is the chances of occurrence of Alzheimer's with this patient could be. So this institute is going to read the 30,000 patients' data spanning over 30 years to make that library together. Now, this is not possible without having a advanced computer science, and an advanced AI algorithm together. So we're going to scan a lot of images. We're going to put all those images together. We're going to use the AI algorithm to understand what is happening with those images. We're going to bring the new patients in. We're going to scan his results. We're going to match the results together with each other. And we understand the predictive model and to understand whether this will be forming into Alzheimer or not. Of course, there is a genomic bank which is getting genomic data bank which is getting generated to understand from science, to help the scientists to understand whether we can rectify this disease or not in the future. However, when we spoke about scale, we also said the time to market of this thing. The need of the hour is to make it much faster. So if you start reading about one genome strand, it generates over 50 gigabyte of data. But to study this whole data together, something which will require years and years of efforts. So we are making a machine along with them which can study a data, which can speed in the whole process of understanding this data together, which is 100 times more faster. So anything which is taking 22 minutes is now taking around 13 seconds for them to research. This is important. This is where the data science comes together with the industry to make the efforts in the field of AI much, much faster. So if we have not computer science, we don't have a storage of that size, it will be difficult for us to make this model work and make it available faster to their patients. So there is a circular relationship between the AI and data. So the importance in the nick of time, we straight away go back to the point, having the whole big data. So the important point you asked is that having a data and a large amount of data doesn't make sense, not all the time. If you look at a lot of data which is not labeled correctly, 70% of the data, this is from the State of AI report done by the Stanford Medicine. And if you look at that data we have today, the 70% of the repeat scans of the 30% of patients were done again and again. So the results might not be so effective. So while we are working as an industry with a lot of people, we always prefer to say, the data has to be more available for this industry to grow much faster, which is the medical science and the healthcare. So that is a basically short message I want to give away from the industry. Any questions, you can always point at us, or you can drop me an email. I'll always take it. Yeah, sure, thank you.
So in one question, please come down. If you positive the time, one question.
So how all these results are validated in terms of their clinical relevance and accuracy?
So that's where we work with the scientist people. We don't validate those results. So largely, we provide a platform through which they can access. They can run those tests and trials and things like that. They can build a model through which they can pass through the data, and the data will predict the analysis of what it is. Now that analysis has to be matched again by the data scientists to understand what is the.
So the clinical part remains pending
with the data science people. Yeah. Thank you.
Thank you very much.
Thank you very much. I now proceed to the next speaker, Professor Mudit Kapoor, who's an associate professor of economics at the Indian Statistical Institute in New Delhi. And so the big question comes in: you have data, you don't have data. Can you actually apply it? How much data is needed, or is it adequate data? Because I always hear on one side there's so much data available and it's not being processed. On the other side, I hear industry saying that there's no data. So where's the gap?
Sure. Very good afternoon to all of you. I feel like I'm a misfit in this conference. But I saw, our organizer here, who's an economist, so I felt very comfortable that the person who is managing this affair is actually an economist. So that gives me a lot of hope. My interest in AI, machine learning, or statistical models is primarily from economics of healthcare delivery. I think this is an important area because, very often in the Indian context, we talk about shortages of healthcare facility, but there's not enough discussion on whether we are efficiently utilizing the existing facilities or not. And I think data and analytics can help us to answer those questions. So there are questions of health, but my interest is much more narrower in terms of economics of healthcare delivery. So that's what I'm going to focus on and talk briefly about some of the research that I've done. This doesn't work, I think. So I just want to start, we economists believe in the statistical thing that all models are wrong, but some are useful. I think this is important to keep in mind that whenever we are using these statistical models, we have to be very, very cautious in interpreting the results. I think we get very excited about the accuracy rates, what are we being accurate about is a big question mark. And in economics, we worry a great deal about it. We worry a great deal about causality, which is sort of AI has not yet gotten there. It is gotten in terms of associations. But I thought I'll start my session with that. But I think the biggest challenge I face as an economist is to work in a multidisciplinary team. And the reason why I talk about, I'll come back to these issues, is that firstly, the problem that we are trying to solve, particularly in public health delivery, is a multidisciplinary problem. It involves doctors, it involves public health specialists, and it also involves economists. And all these individuals or fields come with a very different approach. They don't necessarily have a very similar approach. And one of the biggest challenges I faced working in this area was to build a multidisciplinary team, which was a Herculean task when I started research 3 years ago in this. Firstly, just to sort of give you, before I discuss my research, India has extreme shortages of healthcare. I talked about this. Biggest thing that I'm interested in is how are we using the existing facilities? I mean, are we using it optimally or not? And the biggest challenge I faced was data. You know, you'll be surprised we are talking about so many advances on AI in healthcare. But if you were to ask a public policy administrator, what is the infant mortality rate at the level of a district in India, and a district has 2.5 million people on an average, they will not be able to tell you how it has changed from year to year. It is unfortunate affair that in public health space, there is a huge challenge in terms of data. So all our policies are being determined, you know, by and large, the policies that matter for people are being determined in a data-free environment. And there's a lot of guesswork being involved whether one particular policy works or doesn't work. So this is the unfortunate state in terms of the public health. We have some National Family Health Survey data, but for the first time, this was representative at the district level with a gap of 10 years. And then the government now, the Ministry of Health provides the HMIS data, but that is highly non-reliable. I mean, we've gone verified it at the district hospital level. What is being reported in the HMIS, unfortunately, they don't match up. So without data, I think the big challenge of, I mean, how do we apply AI if we don't have reliable data in public health? But having said that, I then took a very different approach. I went to All India Institute of Medical Science. I mean, I'm just as an economist, and requested if I could do some work which could be remotely related to public health. And my interest started with healthcare delivery was to understand, is there gender discrimination in access to healthcare? Sort of a very simple problem. And AIMS was really interesting because from 2015 onwards, they have digitized the entire data set. And as a result of, but the problem was that this data was in silos. Even the digital director did not know how the data which was coming in a digital format was, how that data is structured, what the tables are. So I spent almost 6-7 months in, I would say, at AIMS, you know, just sort of putting the data together to ask a very simple question, that what is the gender discrimination in access to healthcare? And this was extremely interesting because over here I did use somewhat of machine learning tools where I asked, basically, I sort of set up the model to see that are there patterns of discrimination that could be of interest. And the patterns that were of interest that emerged were in terms of age and distance to the facility. So we knew what was the age of the patient and the distance to the facility. And this was somewhat interesting, I mean, because so far when we talk about gender discrimination, we look at sex ratios at the level of the population. So in other words, if we say that the death rate differs among men and women, then that is the measure of gender discrimination. But gender discrimination could also be when, let's say, women don't die necessarily of a disease. It could just be in terms of access. And this paper was published, you know, very quickly. We wanted to sort of cement a relationship between institutions. So I got this sort of published. But just to tell you, if you look at, you know, in terms of the age group, this is the ratio of male is to female. For age group, for younger age group, it is 2 male patients to 1 female patient. I mean, this discrimination is way beyond the discrimination in the population. And it's interesting, it seems to give an impression that there's a capital good view of the women when it comes to healthcare delivery, which is when the woman is useful in the middle-age group, she's more likely to be brought to the hospital. But when she's in the older group and when she's in the younger group, she's less likely to be brought to the facility. Now, over here, we were using very simple statistical tools. But, to discover these patterns, these relationships, we sort of let the machine sort of help us identify, because we were looking at a very large data set of almost 2.5 million patient visits. AIMS has more than 3 million patients visiting the OPD on an annual basis. That's a very, very large number. The other thing we looked at was distance. So patients primarily come from Bihar, UP, Delhi, and Haryana. What we saw was that the further the facility was from the place, the more likely the discrimination. So in other words, in terms of public policy debate, this should engineer that where should you develop these health facilities? Developing local health facilities is not only providing access to healthcare, but it's also addressing some of the gender discrimination issues. So we also calculated missing female patients based on the overall gender ratio in terms of the population. Almost 50% of women are actually missing. I mean, these are likely women who have the disease but are not brought to the health facility. So this was sort of a big challenge for us. We wanted to sort of see this. Second, where we looked at when I started studying AIMS was to look at this, a very simple problem, once again, not related to health, but an appointment system. And this was a very sort of an important problem, because in AIMS, they worry about overutilization of resource. If you were to just go and visit, you would think that AIMS is very overcrowded. But when we started looking at the data, we found that 70% of the times, actually, there's underutilization of resources, which means if less than 200 patients are walking into a facility. There's a huge problem of no-shows in the facility. People are booking appointments, but they don't show up. So now over here, you need an economist, a statistical model to be able to value overutilization and underutilization. So then we worked with the administration. But the difficult task is explaining the concept of opportunity cost. So when I was talking to a doctor, he said, look, we've given the appointment. If the patient doesn't show up, it's his fault. But the opportunity cost is not the patient who has shown up, but the patient who would have shown up had he or she been given the appointment. So now this is the opportunity cost, that look, there are patients in line who would have shown up, but except we didn't know what is the probability of no-show. So over there, we sort of use some of these machine learning tools to, at the individual level, to classify them based on gender, where are they coming from, which department, to assign a particular probability, then use a mathematical tool to determine how many appointments could they give. And this could take care, for example, of, you could predict it in terms of the temperature or in terms of rainfall. All these factors sort of influence who's likely to show up. And my last research sort of developed when I actually do some work on neonatal mortality. So this developed in the neonatal department I was working, and they asked that, look, a lot of our patients are walking in suspected of infection. Culture reports typically take 72 days to come, but we have to start prescribing antibiotics sort of on an immediate basis, suspecting of infection. So could we have a tool based on the cultural cultural reports that we have from the past to sort of at least have a data or an analytic way of trying to get an idea what is the likely bacteria, gram-negative, gram-positive, what is the likely antibiotic that should be prescribed. So the idea over here is to build an end-to-end solution to see susceptibility, resistance, but at the same time try to identify what the patterns are. But once again, this requires a multidisciplinary team. Fortunately, AIMS, Indian Statistical Institute, IIIT Delhi have gotten together to work on this very important issue. This will take some time, but I believe that it's an important problem which requires data and analytics almost on an immediate basis, because there's a lot of antimicrobial resistance, there's a discussion of superbugs, there's always a discussion of susceptibility and resistance, but I think this is also a practical problem for clinicians, and if we can create a tool which can assist them in a big way, will be helpful. So the only thing I would highlight in terms of the data is that we can use institutional level data, because even though there are some problems associated with it, but we're still talking about an institute. Can I take AIMS data and talk about problems in India? Unfortunately, I cannot. This is a this is not representative at the population level. But the good news is that when our paper got published, at least in gender discrimination, people thought it was simple enough, so it got replicated. It got covered in the media for some reason, and private hospitals thought that the tool was simple enough to compute. And it's unbelievable that in many of the private and public hospitals who shared their results with us, that the table that we have reported is actually they're finding similar gender discrimination in many of the hospitals from where the data came in, or at least some of the preliminary work that these guys have done. So with that, my work, I'm sorry I haven't talked about data quality issue that you had raised. Unfortunately, we don't have data. I mean, once we have data, I'll discuss the data quality issue, but in public health, I don't think the government has shown a lot of interest. For example, in AI, I'm seeing a lot of enthusiasm for people. You talk about AI and that's it, But when we talk about, let's go to the district to collect data on infant mortality, that doesn't seem to be very jazzy at the moment right now. I've been trying to convince the government, let's do it at the district level, because it'll measure outcomes. It'll have political meaning as well, because some districts are improving, which districts are not meeting their sustainable development goals in terms of neonatal mortality. The moment it comes to some hard work, labor-intensive, physical work, I think there is a hesitation to sort of participate. But the moment it is sort of, the moment I say AI, there's a lot of attraction here. What can we do about it? So thank you very much.
Thank you, Dr. Murthy. Please economists, the audience have the privilege of asking 2 lavish questions.
2 lavish.
So I was puzzled by the bias of women and men going to the hospital in India. I looked up the life expectancies of males and females in various countries, and I mean throughout the world, females live longer. I guess because of the lifestyle, probably, not sure. But the difference in life expectancy can be like 10 years.
In some states due to use of vodka, I think.
Yeah.
But if you compare India to other countries and you kind of look at males reaching 66.9, the life expectancy of women as an increase is less than in other countries.
Yes.
So it's only 3 years longer than in other countries. And I'm kind of assuming that women have a more healthy lifestyle in India as well as in other countries. So you think that this bias in medical care use could have to do with that smaller difference in life expectancy?
I mean, there are...
It's very speculative. I just made up these numbers. I just found them.
Yes,
if you look
yes.
at other countries that have numbers like the Philippines are at 65.3 for women, and India is at 66.9 for women, and the male for the males, sorry, 65.3 for the males and 66.9 for the males in India, and it's 69.9 for females in India and 72 for females on the Philippines. So the difference in life expectancy in other countries with a similar life expectancy for males is smaller in India.
For female, it is smaller in India.
Yes.
So of course, gender discrimination in healthcare is of course one of them. But if you look at intra-household allocations within the societal norms also play a very important role. So over here, for example, AIMS is never discriminating. I mean, AIMS is not saying that we are going to treat fewer female patients. It's just that families believe that there's a different cost for a woman. And I think of healthcare as one of the consumption items. You can look at other food items as well. Female child are less likely to be given food. The appropriate quantity of food is first the male child that is provided all the benefits. So this is sort of a reflection of the discrimination that exists. But for the first time, we have some micro level data to sort of understand this. So death rate, unfortunately, does not capture the discrimination. If somebody has an eye condition which doesn't kill, let's say, but to be living with a condition that is easily curable, in my opinion, is also discrimination of an equal magnitude.
Simple question. Do you think it's possible that during the birth review, because of pregnancies and antecedent medical care, rather than there being a discrimination at the two ends before and after it, it is simply greater natural utilization during it.
I couldn't understand. So you believe that?
So you found that during a certain age group,
yes,
the reproductive age group, there was less discrimination. As they got older and perhaps less useful, there was greater discrimination. I would flip that statement and say, during the reproductive childbearing age group, there was a naturally greater contact with the healthcare system, as opposed to a sense of usefulness or uselessness. That would also explain the data equally parsimoniously, without bringing in discrimination.
Well, if you
but that doesn't explain why there is discrimination in the younger age group, even in those conditions which are
not
equal
yet
in
yet childbirth.
At that age, the question of the life expectancy doesn't arise in the age group of 10 to 20. The childbearing doesn't arise. Even there is a lot of discrepancy. So I think the data looks genuine. This may be slightly overrepresented because of the increased use in the middle age, which is the reproductive age group.
Yeah, so no, I think you've answered it, but I wanted to say that it's a U-shaped relationship. 0 to 19, high discrimination. 19 to 45, discrimination goes down, and then again goes up at the elderly stage. So that was the key finding. So, yeah.
And the last speaker.
So next one is we've got two more. Yeah, so we're talking about the financial in the startup world. I know it's a bit interesting to be in sitting between lunch and around doing a good job at pushing things very quickly. But I mean, please put forward
what do you see as the potential of AI and how do you want to take this further?
Sure. I'll draw from two of my previous speakers. I think Professor Kapoor mentioned that where is the data in public health? We talk about building algorithms and building AI engines and stuff like that. And in public health, we often find that data is either sketchy or just plain missing. So this is something that we've found on the ground. One other thing I would like to talk about is no person left behind in this journey, and I think that's really important. There's a project that we're working on with Mumbai District AIDS Control Society that I'll talk about in a bit, where we are essentially trying to address that problem within the context of the ART centers that MDAX works with. I know I'm the second person standing between you guys and lunch, so I'll try to keep it brief. Anything that you can Google, I'll skip over. So just a quick introduction to Avgen. We are a 40 plus people team. We are geographically distributed interdisciplinary team. We are based in London, Mumbai, and Pune. We have had the privilege of touching more than 150,000. It's actually a slightly older number. It's about 180,000 patients through our platform. We have a clinician platform that allows clinicians to work with patients who need longer duration of care, longer episodes of care, such as oncology, cardiac rehabilitation, and maternal health. We have a patient mobile application framework, which allows us to deliver mobile applications quickly for patients to track their vitals and then basically capture that data for further analytics. So something you can Google, I'm sure, has been talked about enough, so I'll just skip over this. Again, has been talked about. The one thing that I would sort of quickly bring up here is, we have seen the evolution. Some of us have seen this evolution in action. And so when I went to do my master's, for example, I had heard of AI. And when I heard about it again a few years ago, I was like, oh, is it the same AI or something new? And algorithms have been around for a long time. They've been around even before computers just probably weren't called algorithms. We have talked enough about this subsets of AI, so I'll again skip over these. One other thing there is NLP, which sort of when you combine all this, you're able to build things that feel like magic, like all our phones that we can talk to retrieve information and so on. My perspective of looking at AI is more that of a foot soldier, because I'm in the business of building software products, and for me, I look at AI as more as a tool and what can I do with it. As an engineer, I think the biggest challenge is actually not the programming. It always feels like, oh, that's that's something really intense. But in the last few years, enough work has been done to make a lot of complex algorithms accessible to people like me who don't really necessarily fully understand everything that goes inside all of those algorithms. But the question is, what can we do with it? Can we bridge some of these gaps that have been identified? So I think it's important to know what AI is good at. I think enough has been said about image recognition and pattern recognition and what AI can do with it. Prediction of time series data. Again, we had a very good presentation about predicting dengue outbreaks. That's a perfect example of how you can collate a lot of different attributes that don't seem related, but can actually help you predict an event in the future. Natural language processing is essentially what happens when you talk to your phones. So knowing all this, there are still plenty of challenges. Again, multiple challenges listed here have already been talked about. So I'll quickly touch on some that I think I have faced personally when implementing software. One of those is healthcare is hyperlocal, and hyperlocal means whatever works in Mumbai does not work in London. In fact, we were at an implementation just 2 weeks ago in London, and we realized what works in Northwest London does not work in East London. So it's really hyper local. So you really have to put things in perspective when you're building these systems. I think integrating whatever intelligence we build, integrating it into the clinical workflow in a natural manner is really critical, because there is a fatigue amongst frontline clinicians to have to enter data into not 1, 2, 3, but many systems, and that's not their primary job, right? So that's something we have to keep in mind. Limited certification guidelines and regulatory guidance. We often hit areas where we really don't know how to certify a particular product that uses AI, what certification is needed, what regulatory compliance, etc., is needed before we put it in production. I'm really privileged to be a part of a work group that's trying to address this problem. Accuracy versus transparency of results. Here, specifically with respect to machine learning and deep learning, we have seen algorithms being used to predict consumer behavior. For example, it's okay for a Walmart deep learning algorithm to predict that whoever buys children's diapers also tend to buy deodorants. You try to explain that in an intuitive way, you really can't, but we know it works. Now that might be fine for predicting consumer behavior, but it may not be fine when making decisions on how to treat a patient, right? So, but then there's a balance we have to strike between accuracy and how intuitively we can explain those results. Last but not the least, liability, because things do go wrong. And I think in commercial applications, it's really important to be able to say with certainty who is liable when things go wrong. So now I'll talk about a specific case study that we are currently conducting in partnership with MDAX, or Mumbai District AIDS Control Society. The results are expected in January of 2020. The program is being rolled out as we speak. This program is actually focused at making sure that nobody is left behind in among the HIV patients that come to these centers. We, in fact, don't call them patients, we call them clients. And one of the challenges that we have seen here is data is managed in spreadsheets. I'm sure all of you have seen it. We have seen spreadsheets with, believe it or not, more than 100,000 patient records that take a lot of time to load, and therefore they feel like too much work to even maintain. So what we're trying to do is learn from the data that already exists. But even before we do that, we really have to focus on doing something useful for them. And so what we're trying to do is reduce LFU, or loss to follow-up. Because a lot of patients or a lot of clients who come to these ART centers, ART is antiretroviral therapy. Sorry, I'm learning my medics still. So a lot of clients who come to these ART centers often drop out. And what happens is when they are diagnosed positive, due to lack of awareness, they don't really know what this condition means. Sometimes it's just a social taboo. I mean, a lot of these clients don't even speak to their family about their condition. And so it's been observed consistently that a lot of these patients just drop off the radar after the first appointment. So what we're trying to do is reduce the loss to follow-ups. And one of the challenges has been to detect the possibility that this person might actually be an LFU. We're doing this by implementing a mobile app that will be given to the clients. The mobile app actually contains educational material that the clients can view in their privacy in their homes or wherever they feel comfortable. This content will be targeted to the patients using an AI engine to see where the deficiencies in understanding are. So this mobile app also contains quizzes to constantly get feedback from the clients. And last but not the least, after gathering all this data, we have a dashboard at the ART center level and also at the district level, which allows them to quickly see which patients might be at risk of being LFU. So the idea is to provide this digital intervention before they are lost to follow-up. Sorry, I must have pressed the wrong button here. Thank you. So quickly, the care pathway, this is what it looks like. A patient gets referred to an ART center, they get enrolled. In fact, just this morning, I got the news that the first patient activated their app and are live now. Engagement gets tracked continuously through the app. A model is continuously learning to see where the gaps in understanding might be, and then push the corresponding content to the patient to bridge those gaps. Retention is hopefully going to be improved as the LFUs are highlighted before they occur. And real-time constant feedback through an analytics dashboard, which helps the ART centers always be on top of how the program is doing. Lessons learned. As I said, the program has just launched, and hopefully, I can present at another such session with concrete numbers of success or failure soon enough. But what we have learned so far, listen to the customer. I think that's key because frontline clinicians, you cannot imagine how they work sitting in an AC office. Make it easy for the frontline clinician to actually use your systems, because the reality on the ground is their attention span is limited. They have limited time when they're dealing with a long queue of patients waiting to be seen. The UX in the field has to be tested in the field. There are things that you tend to ignore when sitting in an IT company, like the devices they use are not iPhone 11s. The network connectivity is poor. Sometimes there is no network and things like that. And last but not the least, build with the model in mind, because you must know what data you're hoping to collect. You must know how you're planning to process it before you start building. So that's just my 2 cents. Thank you very much for listening.
Thank you, Mr. Neeraj. One question from the audience. One question.
Sure. So I have a question. I mean, I find this fascinating, but have you thought about doing something like an RCT Because if you're trying to say that this particular program will reduce loss to follow-up, shouldn't you be doing a controlled trial with some other group where this intervention is not given?
Absolutely. And yes, one of the challenges in doing such programs is also funding them. And so we are actually in process of writing a funding application to do precisely that. What we're doing right now is a small pilot to first of all test that the concept actually works to an extent that it will actually give us meaningful results from an RCT. So we're sort of in a pre-RCT pilot, you might say.
I think if there are no questions, we'll proceed to the next speaker. Thank you very much.
And perfect combination of getting ICMR, engaged with the ICMR to make sure that the evidence comes out of these products. Because otherwise, there's the difference in the vicinities that engineers are doing their own products, and then the other side is doing their own things. I think it's a very important point that the engineers understand that evidence in healthcare is very important. So I think it's an important point. With that, let me give the most difficult task of this afternoon to Professor Andrew Lin to talk about, who's from the School of Computational and Integrative Sciences at the JNU. Because the most difficult I'm saying is because, of course, we all are waiting for lunch and we're way behind. So it's his task to keep us engaged and go forward. So what do you do?
Yeah, well, my title we can just read and move on for lunch, because to this audience, this isn't about the potential for shifting from diagnostics to risk assessment, causality, and therapeutic intervention. I'm going to add the problem that both my earlier speakers did, and that we need to have a data standard in order to move from the first to the second line. Let me move this through quickly. I come from JNU, and JNU is much in the news nowadays because of our students' anti-establishment task. Within a university, we actually take a license towards regulation and ethics, especially with data. But I want to actually bring this out to the rest of you. Institutional ethics review boards don't understand data, don't understand collected data. And this is something that we have to do at the level of WHO and downwards, so that research using data that is not personal or come out from experiments is now part and parcel of future research. Well, we are in India and I work in a university again. We have a lot of young people. And I don't think infrastructure is a problem in this. We have gaming machines, we have algorithms, but we do have a problem with data. And data not so much because of the quantity, but because of the lack of standards. So let's go down. Now, initially I'm going to start off with the fact that we have diagnostics, a lot of them. In the top panel are standard diagnostics, which we define as threshold diagnostics, such as with diabetes, 110 over it, you have diabetes, sugar measurements. On the bottom are images. And our students are interested in moving this forward by using data mining and machine learning to discover new and improved multivariate diagnostics. Now, much of the purpose of setting up this data set came in from the next paper, which was from January of last year. By simple blood tests, multi-analyte blood tests, you now have an early detection of cancer. This is January of last year, over 500 citations since then, okay? The rest, image analysis, a lot of speakers here. I think we'll pass it through. ICMR itself, to my knowledge, has about 60,000 tuberculosis X-ray data. It's not being possibly used properly such that we have a diagnostic which government can use. Now, I'm pretty certain there's a talk later in the evening, but will show us how to use it. But really what we want are standards for image data and possibly competitions for the development of methods which can be translated. Okay, so the next is the excitement within academia, which is on omics. Presently, we have SNP detection, et cetera, and these are current diagnostics which are already used, for instance, for BRCA test, breast cancer, prostate cancer. So we already have risk assessment when we have genome variation mapping. What is exciting and coming up is the higher resolution from single cell data at the level of transcriptome and the epigenetic variation data that we are getting. Now, when we add this through, we have models with the very, very strong potential, not just of predicting age-related disorders. Epigenetics and age is very highly correlated, but we do have the potential for moving towards risk assessment at a much, much higher resolution and level than we've had before. Again, we lack data standards. Now, what I'm talking about and building up is that everything on this panel, we've sort of now taken a step back and we've tried to set up and simulate a data set for applying AI so that you can get from genotype to phenotype. And much like what ImageNet has done for image analysis, we hope that this can be used for data standardization in AI. Okay, now in my lab, we look at causality. If you have a mutation, which is on the left-hand panel, is there a pointer that is? No. Okay, on the left hand, you have genetic variations. Now, as you move up on the panel is a normal structural biology perspective from the structure of the proteins. You can identify, like with sickle cell anemia, if there's a mutation, what is the causality? On the higher panel, the figure on the top, which shows the landscape, volcanic, etc., it is much more physical chemistry perspective to understand neurodegeneration. When a protein aggregates, it is because of the fact that it has an exposed hydrophobic surface with certain mutations, more probable with less mutations. So if we use that, which is a temperature-based unfolding of the protein, we can predict the aggregation potential for a particular mutation, very useful for most neurodegenerative diseases. On the lower panel, as we move down, if a mutation happens in a protein or upstream or downstream of epigenetics, we use much the same algorithms that we use for traffic management. And Google Maps does through networks, both for dynamic mapping as well as structural mapping. So look, within the lab, we actually have methods which can be used to predict the effect of mutations in causing disease or even at risk. Now, these are largely academic questions, and we are academicians, as I said, so they're useful to us. But how do we put them all together into a model so that we put them back together? Now, the central holes or disks over there, transcription network modeling, et cetera, et cetera. Now, I would expect that each of our PhD students sort of picks up one and digs deep into them. They may not be of interest to individuals over here, but when we put them together, they are a superior and more powerful method than being able to predict genotype to phenotype than we've ever had before. Now, what you do with AI is simply looking at features and trying to correlate some patterns towards some phenotype. Here we're looking at causation. I'm going to jump the gun a bit. We had a talk on epidemiology. I'll come back to this slide. So when we are collecting paper epidemiological modeling, this was a paper of mine about 5 years ago. We were predicting hotspot predictions for malaria. And the typical kind of data that you'd use. Can you go to the next slide? Okay. So in the second and the third would be to correlate, for instance, disease incidence under epidemiology and geographical features, which was what is done. Now we sit on one data set of enormous value, which is essentially the census data from our country in our university. So one of my brighter students put together other things, which are socioeconomic patterns. Now, what we found, what he was excited on was, being from JNU, was the discrimination in wealth, etc., associated. Poorer people were getting malaria. But I found that there was a better predictor, which was workforce participation. And essentially, this is useful for policy. What happens is that if you do not have local labor towards construction, you're importing and migrating labor for construction, and disease comes in from there. And construction activity itself is useful for the vector movement. And this was the biggest hotspot in our country for malaria, and an easier predictor than most other things. So you see, what you need to do is look at patterns where we can put together data from outside of the standard medical line. So I'll go back to this. One of my students has just picked up a very inexpensive Arduino Raspberry Pi based stuff. He wants to study the effect of why I snore so loudly in class. essentially, the law is different with geography. I have 85 million articles, scientific articles in my lab, and therefore it is probably the only resource in the world you can do NLP. And it is only legal in my country, and I'm the only one who has it. And you see that these kind of things are important with reference to law. With ethics, that's a little different. So we're doing some sort of a mining in which we can pick out all this kind of data and put it together. Dietary habits is of importance to me for another reason. With tuberculosis, our country gives 500 rupees to every TB patient. Now, I know that people in Kerala, because they eat black pepper, have a significant modulation on the drug regimen than normal people. So can we get this kind of data correlated together? So what we've got is, we've got this data set in place now. We have the genetics, we have the genetic variation, we have our ability to model in between, and we've got an open-ended set of environmental parameters. Excuse me. So what I'm doing is I'm using this for dystrophy and calpainopathy because we can back calculate the genotypic data. But we are setting a framework, much as the question you asked, a set of standards for data such that this data framework can be adopted by communities. And therefore you can get a distributed data set which can be used for AI. Okay, I'll stop here. Thank you.
Thank you. Lunchtime and last speaker is always a lethal combination. I only ask one question.
Yes, sir.
So I just been to a very inspiring conference, and there was a talk by somebody about the problem of standards and formats, and in particular of annotation. So ImageNet was produced through Mechanical Turk, right?
Right.
And the idea that was brought up there is an app that, or a mechanism that would allow the medical community to do coordinated annotation work on data sets. And I'm asking you this question because you are familiar with the complexity of the whole problem. Do you think it is feasible to start to consider creating such an app where you would, I mean, with pictures, I can myself see it quite well feasible to create an annotation task and basically have volunteers to start annotating, and then have statistical mechanism to like sort out those who are not experts, etc. So you could think of it, but given all the complexities that you pointed out, do you think still it makes sense to create such an app?
It definitely does. For instance, even with image data, you can annotate it using CAPTCHA technology by crowdsourcing. Now, just two quick answers to this. The first is that data translation towards standards is an extremely important and understood problem in the scientific community. Last year, we had an international conference on bioinformatics. 30% of submissions were in translation to standardized hospital information records. 30% of the papers. And we're not talking about methods and other things, we're talking about data standardization. Now, we were part of a project called the Open Source Drug Discovery. Professor Samir Brahmachari is doing it. And we crowdsourced, and this was 10 years ago, the annotation of the tuberculosis genome. The technology works, it's quite easy to use, and it's there. And in my own lab, because I have such a large corpus of text, to create an annotated tagged text, there are two sections. One is with text tagging, and the other one is much like you would use the Tinder app, but for images that are associated with medical imaging for tagging. So the answer is yes, the technologies exist, and they're easily translated and scaled to crowdsourcing.
Yeah, my chair has vetoed me. I have another question, but you want first.
No, there's a question behind.
Not you.
Thank you. Thank you so much for allowing the questions. So I like the use of causality. So like it will be very complex systems to actually, there's a lot of nonlinear systems, I could say, that causes an effect. So how are you just trying to like apply causality, and what type of causality you apply?
I gave you three examples, but I'm going to repeat them again. The first is at the individual protein level, at its structure, change in a mutation can cause change in its function. The second is at the level of the proteins aggregation abnormality, which is in neurodegenerative diseases. And the third is the static topological movement, much like Google Maps uses its algorithms and traffic movement. If you have a defective node, you can work through that. And the fourth is the dynamic properties, which we use, for instance, with metabolic modeling. Okay, so they are standard methods, and they're actually quite effective, but they're in their silos they don't really get integrated together. So we've integrated them together towards disease map.
I just want to add one thing, that I think this causality will help us to go to the precision medicine and personalized medicine development at some point.
Right.
Maybe the future.
Again, a quick answer to that, although we are at lunch. See, the thing is that I believe that a lot can be done with nutritional tuning of a complex system. And that is where we are looking at nutrition and diet as an add-on, micronutrient as well as other things, as added portions of this data set, right?
Thank you.
Thank you so much, Professor. For bringing that. So please. Thank you very much for the very intense speakers for putting out the very specific points. I think we have a lot of food for thought that we're going to the lunch for. But I think that to summarize this session, I would clearly mark out that the need for the data is a crucial one that we have to address. And the focus was, as we're calling it, WHO data is not a new gold, not a new water, it's new blood to public health. And so it's an important aspect that we can. We have already started looking at the ethics work and regulations work in the focus group. So we will take the standards and the structures of data as a key with us as well. And I think we will learn a lot. Thank you again for the very rich and insightful comments.
I have only announcement on behalf of the organizers. We are proceeding to lunch to where we have the tea in the cafeteria, and we'll shortly come back and come to this hall by 2:45 p.m. Thank you very much.
Thank you, Chair. Thank you, speakers.